conversation, but our seniors deserve better than this. Coloradans with Medicare Advantage consistently tell me that my office, that their surgeries are delayed often for months, that they were lied to about their level of coverage or that their plan was too expensive, and that their claims are denied when they're told services, should have been or would have been covered. All of this demonstrates, I think, that we need greater transparency. And so, Ms. Red.
Hey guys, Justin Brock here. The Senate Finance Committee recently had a hearing where they interviewed people from the agent and broker community, SHIP, and even a Medicare Advantage plan sponsor and some other organizations to try to get a grasp on what are the issues within the Medicare Advantage in the Medicare Advantage environment right now. They're citing rapid complaints going up and up and up, right? And so they're trying to figure out what is going on, okay? And so I'm going to get into some of these point by point. But before I do that, I want to say that as recently as going into 2022 and then going into 2023, they've made some huge new compliance requirements for agents. One thing they did was they made every agent, regardless of their status, their complaint ratio, anything in the entire country, record every single sales call they had that resulted in a Medicare Advantage plan or a standalone Part D plan. Remember that a standalone Part D plan goes with traditional Medicare and a supplement. So every one of those calls now has to be recorded. No carve out for standalone Part D, which is a little ludicrous. Also, the another thing they did is they created a 48-hour cool down period, but then right as it was about to take effect, there was some unfortunate back and forth between CMS and different entities on whether an inbound call was created an opportunity that circumvented the 48-hour scope requirement, meaning if someone called into an office, did they have to do a 48-hour scope of appointment? A 48-hour scope of appointment is just saying that if I call you outbound, if I say, hey, you went on our website, you gave me your name and phone number, and then I call you and say, did you need any help with your Medicare plan? That before I can enroll you in a Medicare Advantage or standalone Part D plan, I need to set an appointment for 48 hours out to allow you time to think about it and cool down. But right now, they're saying that inbound calls circumvent this issue, this need for a 48-hour cool down period. And unfortunately, some bad actors out there who we'll identify as time goes on in this video are utilizing practices like making someone from outside the country call you and then ask you a question, and then when you say yes, they transfer you back to that agent or agency or call center, mostly here in the United States, and then they treat that as an inbound call, even though it started as an outbound call outside the U.S., and those call recordings will never be shared because they're by entities outside the U.S. I went to the Hill, sat in Senator's office with healthcare aides, and made the recommendation that they make it non-compliant for a sale to be initiated on a call that is outbound from outside the United States, and that would reduce the overwhelming majority of these complaints. But instead, they're turning this into a political show, I think, and they're trying to paint the picture as agents and brokers being overpaid or Medicare Advantage plans being the problem. They're trying to paint Medicare Advantage plans poorly, and they're comparing them probably to an unfair standard of comparing them to Plan F and Plan G supplemented Medicare, traditional Medicare, which a lot of these people do have the opportunity to get, but some of them do not have the opportunity to get. And so this misinformation that's being perpetuated out there can be rough. Now, as you're watching these, if you need help with this, you can go to BobbyBrockInsurance.com, where we present both sides of the aisle. We have as many or more customers on traditional Medicare with supplements and standalone Part D plans as we do Medicare Advantage plans, and that includes people who are dual eligible for Medicare and Medicaid. We can help with all scenarios, no matter your vice, and anyone that tells you that only one side it works 100% of the time is flat wrong, and they're pandering to fear, unfortunately. So I'm going to get into some of these videos. And the first video that I was watching here is Senator Michael Bennet from Colorado talking about delays and denials. And one of the things that he talks about is a hospital called San Luis Valley Health in Colorado. And someone there saying in the last 6 months, they have submitted 45 requests to admit someone to the hospital and had 45 denials in 6 months. So, Medicare Advantage hospitalization denials are not an extremely commonplace thing. Now, we had this several years ago where there was a hospital system right in my backyard in rural Mississippi that was saying the same thing. I believe they quoted something like 93 or 98% of their hospital claims were denied by Humana at the time. Fast forward to today, they are actively taking almost all Medicare Advantage plans and even have a co-sponsored Medicare Advantage plan themselves. The issue when prodded now is that their billing staff was not adequately trained on how to file a Medicare Advantage plan claim, as it is different than filing against traditional Medicare. Traditional Medicare, you're filing against bureaucracy and taxpayer-funded health care, which Medicare Advantage is still taxpayer-funded, but with a private counterpart in that the insurance company or plan sponsor is actually trying to manage that amount of money and make sure that it is efficiently used. And so they are looking at claims. Are they denying claims? They're not allowed to deny claims that would otherwise have been approved by traditional Medicare Parts A and B. It isn't allowed. So anyone that's saying that they had a 100% denial rate is what for sure, 100% for sure, not filing these approvals correctly. It's a statistical anomaly. And to further drive home the fact that this is a rural healthcare system issue typically, I did a little bit of research, but one thing, I didn't have to do research at all to know that 45 hospitalization claims in 6 months on Medicare Advantage plans means they don't have a lot of Medicare Advantage in the area, and 45 claims, that's it? That's all, your whole hospital, 45 people were on Medicare Advantage plans in a 6-month period being hospitalized. So they have very few Medicare Advantage plans. And San Luis is actually in a town, I'll probably butcher this, called Alamosa, Colorado. Population is 9,814. Now, I'm sure that hospital is a great hospital. I'm sure Alamosa is a great community. But this drives home the point that this is a rural hospital issue. We're getting down into the rural hospitals. If you live in a town that's 50,000 or 100,000 or 1,000,000 or 500,000 or 300,000, you're probably not experiencing the same thing. And so when these anecdotal scenarios are used, when there's a small rural health facility who is inexperienced in filing Medicare Advantage claims, with 100% disapproval rating on hospital admissions, pretty blatantly obvious that there's some training that needs to occur before we start getting on national television on C-SPAN and criticizing the entire Medicare Advantage program and all Medicare Advantage carriers when this is an anecdotal issue. Anecdotal. Now, does that mean Medicare Advantage plans are not, subject to some issues? We definitely see that traditional Medicare approves claims and admissions faster. But when rationally adjusted in the right area, let's say an area that has hospital systems and providers that have become more pro Medicare Advantage or more agnostic as to what you're getting, the difference is minute. It's not very big at all. Now, if I was trying to sell everyone a Medicare supplement, or I was on a marketing tirade on YouTube, I might go out there and use these anecdotal scenarios as a reason that everyone should get a Medicare supplement, knowing that everyone cannot get a Medicare supplement, but thus driving people back to me as the savior of people on Medicare because I'm going to be honest with you. And then when you get on the phone with me and I find out that you can't get a Medicare supplement, I still let you know that maybe a Medicare Advantage plan is in your best interest, and then I get to educate you on why. That is what is happening in some of the marketing, but it's become a thorn in the side of the people that have been helping people with both sides all along, because now every annual enrollment, these viral YouTube videos go around telling people they should get off of their Medicare Advantage plan. Many of these people cannot get a Medicare supplement, and some of them end up going back to traditional Medicare with no supplement, and thus being subject to an unlimited 20% coinsurance, unlimited hospital admission deductibles, and unlimited hospital daily copays and skilled nursing facility daily copays. So this is an issue rooted in some of these anecdotal issues or these anecdotal scenarios. And that's important because facts tell and stories sell. What Mr. Bennett knows is that he just told you a story about a nice hospital system who had a 100% denial rating, but when prodded just a little bit more for information, we're able to see exactly why that is, what most likely the issue is. And if a Medicare Advantage carrier who's in that area right now is really interested in helping, they would reach out to the senator, bridge the gap with that hospital system, and go in and say, let us help you figure out where the disconnect is so we can bridge that gap. And these carriers have been making leaps and bounds on this stuff. So I'm going to move on to the next video here, and I'm going to watch that now.
A year and a half ago, nobody knew what a ghost network was. But a ghost network is what it sounds like. Somebody buys a mental health insurance policy, and they expect they're going to get some services. But after they buy it, after the contract is signed, and they actually need it, the ghost network basically has no there there. You can't find a doctor. You can't get information about what hours of service they might keep. There's just nothing to follow up on, and certainly nothing resembling the healthcare services you thought you bought. So our investigators looked at a cross-section of mental health plans across the country. They contacted the providers. They asked if they could get an appointment for a family member. They were able to get an appointment 18% of the time. So more than 80% of the time, their plan actually failed them. Even if a senior could make an appointment with provider and get this, they may be exposed to extra costs if they have to go to a provider out of network. In other words, they paid for something, there wasn't any service, they need some health services, they go out of network, and the person they gave the money to originally sticks them with the second bill.
Okay, in this video, Mr. Wyden actually makes some great points. Mental health care facilities, doctors, providers in the network for Obamacare plans, Medicare Advantage plans, and even traditional Medicare is barren, extremely barren. And so, in this video, in this part of this committee, considering that Medicare Advantage was the topic, I do think the disingenuous part of this bullet point is that it's not specific to just Medicare Advantage. This is a problem across all healthcare. Medicaid, Medicare Advantage, traditional Medicare with a supplement, people with Medicare and Medicaid, as well as Obamacare and the Affordable Care Act, potentially even some group health insurance. And a lot of this has to do with the mental health care facilities reimbursement rates under this. They don't feel that it's adequate, and so they're not as prone to participate in it. That's what we've seen when I've talked to these mental health professionals. Many of them are not. And then there are a lot of mental health professionals that are, licensed therapists, but they're not full-blown clinical psychologists. They're also fragmented. They work independently a lot rather than within specialty groups. If you'll notice, there's not normally like how you would have a urologist group or urology group in a town with multiple urologists working there, or you have a cardiology group with multiple cardiologists. You don't normally have a decent business made out of a group of psychologists or psychiatrists. And if you had that, you would probably have more insurance involvement. But when it's a lot of individual clinicians or psychologists, psychiatrists, licensed physical or licensed therapists, the likelihood that they're all going to join these networks is low, considering right now, since most of them aren't taking a lot of insurance, they kind of have the pick of the litter on the people who can cash pay. And that is an issue, and it is one that definitely needs addressing, and I'm glad they're addressing it. I just think we need to make sure that we know that that's a healthcare issue across the board, not specific to Medicare Advantage. If there was a true non-biased study, which very seldom exists anymore, if true non-biased study about which sector of healthcare, ACA, Medicare Advantage, traditional Medicare, was doing poorest in the amount of actual mental health care professionals and facilities in the network, I would think that you wouldn't see a big disparity between Medicare Advantage and Obamacare, or even probably traditional Medicare and Medicaid. So I'll move on from that point in that video, but great point that definitely should be addressed. Not sure what the solution is on it. But I think it's going to come from the provider side. There are going to need to be some focus groups with providers. A lot of these industries sometimes get consolidated with specialty groups forming, and it's possible that some consolidation in the in that arena would be good. Potentially reimbursement rates going up for them, albeit anytime I feel like I feel the need to advocate for spending more money from the government, I also feel the need to remind everyone that there isn't any more money. They just keep printing it. So that might be a short-term solution that causes adds to another large problem. So we'll move on from that topic.
I have heard from Nevadans, including in staff in my own state, in my own office, who are trying to help their parents. And they are trying to enroll in Medicare coverage for the first time. They meet with a broker or see an advertisement about Medicare Advantage plans offering $0 premiums and boundless supplemental benefits. Sounds good, sometimes too good to be true. Are advertisements like this misleading? And if they are, what should federal government, what should we be doing about it?
They are, and this has gone on for years. We, on all of our public presentations and our counseling, we beg the consumers, do not choose your health, your prescription drug coverage based on an advertisement. The advertisements will focus on the zero premium, zero copay at a primary care, maybe no copay for generic medication. But we really want them to look at things like, what is the copay for inpatient hospitalization per day? And when it comes to Medicare Advantage, also know that maximum out of pocket, which would be a limit to their financial risk. So the advertisements over the years have gotten more aggressive, and they do focus on those added benefits, specifically cash allowances, debit cards, money to go into the local drugstore and purchase items that aren't covered. And we have counseled numerous individuals, especially over the past open enrollment year. They were very upset with us because we could not use Medicare's Plan Finder tool to order the plans in order of the highest debit card to the lowest. And when we try to circle back to things like their specific providers, mental health needs, and other critically needed services, they really want to focus on those added benefits. And that has been a challenge for us due to the advertisements.
All right, another question here coming from the senator from Nevada, Cortez, this Cortez Masto from Nevada. And she is phrasing the question about advertising in misleading commercials. Television commercials seems to be what she's honing on mostly. So the television commercials, anybody who's really in the business has already seen that they've started to go down. The effectiveness of them went down, but I don't think it's any secret to anyone that the Joe Namath and eventually J.J. Walker and other celebrity commercials around the country definitely identified a group of people who were looking for benefits, money, cash, etc., dental benefits, and not really as concerned, most of them not really as concerned with the healthcare benefit at the time. So it did bring a lot of that to light. I think it's important when listening to this bullet point, though, that at this time that they're putting this out, a lot has already been done to curb this. A lot has already been done. And they talk about it as if it hasn't and there's more to do. I hate to, say this, but it's like in an election year, they always want, things to look like we're doing something for the constituents and we're trying to help them and all this. But they actually have already put a lot of new marketing compliance in place. The recording of all these phone calls, and just think about this, guys. Most brokers and agents that are trustworthy, good agents and brokers around the country that are 50, 55, 60, 65. Some of these people have been doing this for 20, 25, 30 years and have 99 point whatever percent satisfaction ratings with their customers, no complaints or almost no complaints ever in their entire career, that are out there doing the right thing, are now having to learn how to create some sort of software, install some sort of software program, and store all of their calls on terabytes worth of memory that they then have to be able to furnish at the request of anyone all the time. And unfortunately, it's so rough to see agents retiring saying, I'm not going to adapt to this environment. And we're actually losing good agents because of this, instead of going out and finding the bad actors, because there are bad actors, agents. There are bad agents out there. There are bad agents that are not doing what's right for people. And they already have the mechanisms in place to find, identify, and get these agents out, help get their licenses terminated, find the patterns, and then find the marketing groups that are out there, mostly large publicly traded call centers that have to show a growth in membership for their almighty share price, for their Q1 and Q2 profits, so their executives get bonuses. This is not small town agencies. We have an agency in Tupelo, Mississippi, and we have clients in all 50 states. But a lot of our clients are Tupelo, Mississippi, Southwest Tennessee, Northwest Alabama. We have a lot in Central Texas, and a lot of these clients that we have, we're focusing on sitting down with them one-on-one or on the phone and going over this information, picking whatever they want to pick by going over this factual information, going over from an educational standpoint. And it's just really sad to see, agencies like that and smaller agencies than us and agents that are doing the right thing get held to standards that are more difficult for them. And these large call centers have no problem popping up the little disclaimers that say, hey, I don't have all the plans. You should call 1-800-MEDICARE. And they'll throw them on this little recording that's just like Big Pharma does. Meanwhile, a small town agent's actually reading it off of a piece of paper every time the way he feels like he's supposed to, he or she. And they're the ones that are coming under undue scrutiny because no one wants to drill down and find the real problem children here. The problem child is not Medicare Advantage. It's not Medicare Supplement. These are not one-size-fits-all plans. These are plans and paths for some people and not for others. The problem is the large abusers. And if you can't find a way to police them without hurting everybody else, that's just a shame. But what she's talking about here, these commercials, and then the ship counselor, from Ohio, comes on and talks about how these commercials are problems, and people do call them, and they're mad that they cannot sort by the amount of money that they're getting back. Now, on the consumer side, a lot of this is consumer-driven marketing adjustment. The consumers don't if you're watching this, you're probably a consumer that cares about your healthcare needs. It cares about what Medicare plan you should get or shouldn't get. But a lot of people are driven by the amount of freebies they're going to get. And to be honest, they wouldn't even have a Medicare plan otherwise. And so, a lot of times when they'll get a Medicare Advantage plan that has zero deductible, zero premium, it's giving them, $95 a quarter for over-the-counter benefits and maybe $2,000 worth of dental, and putting a cap of, let's say, $5,000 on their out-of-pocket annually. That to them is actually a great deal. And they're not as worried about the out-of-pocket because that's not what they came to that plan for. But the good news is now that private entity has a cap on their out-of-pocket, whereas if they would have stayed with traditional Medicare only, they'd have had no cap on that out-of-pocket, which would have eventually just went to those hospitals and that's what. It's funny that some of these small rural hospitals haven't figured this out yet, is they're going to, when they adapt, end up better. And it's coming, guys. I mean, the Medicare Advantage penetration rate nationally is 52% at the end of this summer. It was 52%. And some of these Medicare Advantage carriers now have nationwide PPOs that's network of doctors and facilities actually battles against the strength of traditional Medicare's network. So I would think, you should definitely look at this from like not being biased. Medicare Supplement, Medicare Advantage. My bias is we want you to be our client. My bias is not towards Medicare Advantage or Medicare Supplement plans, but one is not the devil and one is not the savior. There's the battle between good and better, not good and bad or good and awful. And people are not getting on Medicare Advantage plans and dying because of the Medicare Advantage prior authorization issues. That it would be some sort of anecdotal response. We saw a lot of that when Obamacare was initially signed, that people before Obamacare was signed were dying, and then we saw people putting out stories about the catastrophe caused by Obamacare to them, et cetera. Just blatant misinformation that gets spewed around by the opposing political opinion, which I think is what we're seeing a lot of on this finance committee. So we're going to get to the next video. I'm going to watch that right now.
Now, in 2019, the Health and Human Services Inspector General found that Medicare Advantage insurers improperly denied payment for care in roughly 1 out of 5 claims, leaving seniors with piles of unpaid medical bills. And just 2 months last year, the giant insurance company Cigna used a computer algorithm to instantly deny payment for 300,000 claims, even though trained doctors are supposed to make those determinations. Ms. Hoagland, giant Medicare Advantage insurers are overcharging the government. They are peddling false promises, and then they're turning around and denying care to seniors and people with disabilities. So this is why CMS has taken steps to start to crack down on deceptive marketing and unfair denials of care. Do you think that the government's proposals go far enough?
No, I think there is more opportunity. And again, that's why we're here today. One of the things that we specifically have suggested around the marketing tactics that are currently out there and the additional payments that we see going to FMOs or middlemen is to really require some additional transparency so that it's very clear what all the dollars are and how they're flowing, and understanding who might be the bad actors, so that those can be addressed specifically. And then really thinking about, once we understand how the money flows, how do we put true maximum caps on some of these items so that they can't continue to be leveraged for financial gain.
Okay, so next video we're going over is this one here, where Elizabeth Warren, Senator Elizabeth Warren, needs no introduction, is asking a question to Krista Hoagland, who is the CEO of Security Health Plan, if the new CMS marketing and sales and other things that restrictions that CMS has started to impose on agents and brokers is enough. And she says no. So a couple of things. First, Senator Elizabeth Warren, as always, cites a couple of things and then ties them into an outlandish claim with a lot of grandiose accusations, kind of bridging that small anecdotal fact to huge grandiose things like, oh, this is terrible because all this is happening, right? And it's not so we're going to bring them down just a little bit here, to say, look, some of the issues that she's talking about early on is in 2019, an Inspector General report that says that 1 in 5 claims are denied, and that there were 300,000 claims denials, et cetera. Those numbers sound big. First of all, 2019 in Medicare Advantage is ancient history. The program isn't that old. In 2019, a study was probably going off 2016, 2017, 2018 data. And so that's probably drastically less than 1 in 5 now. But those claims they're talking about, they were probably using algorithms and AI, which are getting better and better and better and more efficient. And when costs can be cut, we can save that cost there. They can pay out more in claims. So that is technically a good push. But having, an algorithmic response, is going to come with its hurdles. And so probably doing a lot better than that now. I haven't looked at the exact data, but that it would be considered pretty old data in the Medicare Advantage world. She also used 300,000 claims denials. It's important to know that billions of claims are paid annually. Billions of claims, billions. So this 300,000 number in the grand scheme actually ends up being a pretty small number. And then that doesn't say how many times they came back and filed it and then it was approved the second time, which would probably be a lion's share of them. Going into Krista here. So Krista, the CEO of Security Health Plan, it's important to note who was asked to speak at this Senate Finance Committee meeting. So we have Krista Hoagland's the CEO of Security Health Plan. It's a small regional or small area Medicare Advantage or health plan, right? So there is no representative from United Healthcare, the nation's largest Medicare Advantage plan. There's no representative of Humana, the nation's second largest. No representative of CVS, the nation's third largest. No representative from Centene or Kaiser Permanente. No representative from Cigna Healthcare. No representative from any Blue Cross Blue Shield entity like Blue Cross Blue Shield of Florida, Blue Cross Blue Shield of Michigan, which has very high Medicare Advantage enrollment. Or any of the other Blue Cross Blue Shield associations. That is pretty interesting to me because they did not want to talk to the largest, most experienced groups. They wanted to talk to a small group, probably the only Medicare Advantage plan sponsor that I know of that is actively advocating for less ability to compensate marketing groups and agents for the distribution of their plan. Now, why would they do this? Okay, so in business, you have a cost to acquire a client. When you only have a handful of clients, you might get them through your warm market, but at a certain point, you have to advertise. You have to have an administrative burden, an operational burden, a sales burden to your organization, and that's going to cost you money to acquire a client. Doesn't matter what the product is. At some point, it's going to cost some amount of money to distribute that product. And most of the distribution cost for a health plan is sales and marketing. And the only group, and this is a group that uses agents, and I believe what is happening is they're paying their agents the street level, CMS approved Medicare Advantage compensation. And their agents are saying, well, there's a higher administrative fee or marketing support from Centene and these other organizations, and we would like to write more of that plan. And so they're advocating for lower caps and controls on the administrative fee and marketing support that these groups can give agents and agency owners. Unfortunately, what this will lead to, if this happens, is a big shakeup in the marketing organization world for Medicare, and it could be have a domino effect into the health plans themselves. It's important to note that these agents are also a lot of the agents that are helping people enroll in standalone Part D plans with their traditional Medicare and Medicare supplements. Standalone Part D plans already don't pay agents worth a flip, even though they require just about as much diligence as the placement of a Medicare Advantage plan does. And so this is, in my opinion, it seems to be a self-serving advice because if we can make everyone else pay their agents less, then we'll look more competitive with what we're already paying. versus trying to figure out how to play them more or how to entice them to sell the plan by saying, look, we're not going to pay as much, but our plan is going to have higher patient and client satisfaction, meaning it's going to stay on the books longer. You're going to have less administrative burden trying to keep your clients happy and on the books. We're going to help offset that by having a heftier claims division. We have insurance carriers right now that pay us less than others that we write just as much of. So that's already a thing. Now, the reason we do that is typically they spend that money creating higher client satisfaction. They have their patients or their clients, their policy holders more satisfied, meaning I can go worry about new clients because my clients are more satisfied with the plan that they have. That's already a thing. We already have that. The only groups that are driving sales, 99% of the groups that are driving sales to the highest paying entities only are Go Health, Select Quote, and those would be the primary two. There's the large call centers, and most of these call centers are still doing marketing practices that nobody's bringing up. They're buying transfer calls from Pakistan and India. How many of you have gotten calls from Pakistan or India from somebody asking you if you have Medicare Part A and B, and if you make your own healthcare decisions, then transferring you to another guy who's probably from India as well, but speaks a little bit better English than the first guy. And then he confirms again your birthday and your age, and then he transfers you back to a fronter in the United States or an agent in the United States, and they say they're with Select Quote or Go Health. 99% of the time, Select Quote, Go Health. This year, it's a lot of Select Quote. This type of BS is what the real problem is. And they have all these committee hearings and all these people with their self-serving jargon, and they're not even admitting what the real problem is. Okay, so Krista Hoagland, I don't know Krista, but my assessment is from this, it's potentially self-serving advice. I haven't heard a rebuttal from anyone. This hearing is a witch hunt. They have clearly assembled the people that are they want to share their opinion because they already know what their opinion is and they want it out there, as part of a propaganda machine. So and it worked. Now you have people on YouTube that are chopping this content up and using it to scare you into specific plan choices or make them look like they're the good guy. I could get on here and do the same thing. I'd be like, listen to Krista Hoagland. See, these people are getting paid too much. You should get a Medicare supplement with me because they're not able to pay administrative fees. I could say that. And the obvious answer is you should go with an agent or brokerage that you trust to actually get you quality information, which is what we do here at Bobby Brock Insurance. So go over to BobbyBrockInsurance.com if you need help. I'm going to go on to the next video.
This constituent cares for her 26-year-old son who has a developmental disability and is eligible for Medicare. Her son was on traditional Medicare, but a Medicare Advantage marketing agent called his cell phone and got him to agree to switch his insurance. This company took advantage of him during a 5-minute conversation, leaving him with a plan that would not fully cover his healthcare needs. The good news is that his family found out about it the same day and was able to undo the changes just in time. But unfortunately, there is nothing stopping, as we've heard, this kind of unscrupulous marketing for these plans, and nothing stopping them from targeting the most vulnerable patients who may not have the resources that they need to navigate this kind of conversation. So, Ms. Reg, how can we prevent these kinds of tactics from impacting our most vulnerable populations?
I agree. I'm sorry to hear that story, but it's a story we hear time and time again. We've counseled individuals both under 65 on Medicare due to disabilities and individuals over 65, but with extreme cognitive impairments. And the record that we're able to view on Medicare's system through Marks shows an enrollment almost every month, which is far exceeding what the low-income subsidy special enrollment period allows. So we do file the complaints. And I think, again, knowing who that agent on record would allow us to take a step further in the side of enforcing those rules.
Okay, so the next question we got here from Senator Hassan. Again, facts tell and stories sell. These politicians don't, first of all, let's all identify that politicians are salespeople. They've sold themselves into these seats. And sometimes it's benevolent action. Other times it's a narcissistic action that they think they should rule over a certain group or or represent constituents. But I don't want to talk bad about any of them. We don't know what their intentions are, but they are salespeople. And one of the reasons I know they're salespeople is they keep using stories. Facts tell, stories sell. It's what salespeople learn. It's one of the main things we learn. And in this story, she talks about a constituent who has a son who is 26 and disabled. And in a 5-minute conversation, she says this agent calls the son and in 5 minutes changes him to a Medicare Advantage plan. And then the ship counselor says that she hears this all the time. Well, let's just get down to brass tacks here. Nobody's hearing that story all the time. And if they are, it is not true. Listen. Does that happen? Has that happened? Potentially. Is that a commonplace thing that on an outbound phone call, someone in 5 minutes is changing a disabled person from traditional Medicare to a Medicare Advantage plan? I think that is very uncommon, almost non-existent. Her son says that there's nothing there to stop this from happening. Okay, there's no marketing rules or no sales rules. And that's not true. It's not true at all, because right now there's already a call recording requirement they put in there. That call would have had to been authorized. Also, they already have it where if you're on an outbound phone call like that, you would have to do a 48-hour scope of appointment and set it up for him to either call you back to initiate an inbound phone call, or the appointment would have to be 2 days later to give them a cool down period. You also have to ask the question, are you making these health decisions? Are you on, or does someone else help you make these decisions? Those are requirements. So if that happened, if that really happened, then those people could find out who that agent was from the carrier, and they could report them to CMS. They would be a violation. They would pull the call recording, and then that person could lose their ability or be punished, especially if they notice a pattern of that. I think that's very uncommon. It's very uncommon. I've heard of an agent doing things like that before, and those agents have lost their appointment. I know Humana and United Healthcare specifically terminated an agent who was doing something not exactly like that, but similar, where they weren't following scope of appointment practices, and they noticed a pattern of this happening on complaints, and they terminated the agent. So it does happen, but that specific story, that story sells how bad this is. Unfortunately, it's again is anecdotal and being used to fearmonger this stuff. Because and the ship counselor says that for them to be able to look up that agent of record, that would help them punish it. It would help them report the agent of record based on hearsay, because I have had customers sit with me and do standalone Part D applications where we looked up all their prescriptions, printed out exactly what their prescription costs would be with those plans, and then see on a transcript from a Medicare complaint that someone was coaching them into complaining to change mid-year without a special election period. And they were coaching them by saying, my agent told me all the drugs would be free. So there are times where these people lie because they're either embarrassed at what they got or something like that. And I'm not saying every complaint is a lie. It's not. There's some of these complaints are certainly valid, and a lot of these complaints, I bet, are coming where they're complaining about the calls they're getting, not actually complaining about the enrollment, because I think a lot of these people are not even doing an enrollment. They're complaining about it. Sometimes you also have children that are complaining about the choice their parent made, and the parents are just kind of backing down to the children. So there's a lot of different variables in this, but to act like 26-year-old disabled people are getting bamboozled in 5 minutes on outbound phone calls is a rampant problem. That's just crazy. It's just nonsense, fear-mongering. And that's all I got to say. We're going to move on to the next video.
It's simple. Responsible insurers don't lie and cheat seniors to make a buck. But it's clear that the big Medicare Advantage insurers aren't playing by the same set of rules as some of the smaller insurers. And I appreciate the steps that CMS has already taken, but they need to go further by making the Medicare Advantage insurers publish accurate data on patient care and out-of-pocket costs, and cracking down on practices like upcoding. doing all of this to the full extent of their authority.
So in this next video, Senator Elizabeth Warren is talking about, is her ending statement, and she's talking about upcoding and Medicare Advantage, the largest Medicare Advantage insurers not playing by the same rules as smaller insurers. I do think it's important to note that these large entities are made up mostly by employees and shareholders, and that their day-to-day operations are, tied to revenue, but they have to continuously grow gross and net revenue. So the goal is not to, to do anything to pinch out additional money today. There is a long and a short-term goal simultaneously going on. So I don't think that there's any sort of evil, bad intent here. I think that they're trying to grow and they're consistently adapting to the market that they're in. I do think Medicare Advantage overrides and the chase for overrides and marketing dollars has steered some large groups in the wrong direction. Unfortunately, I think that the small to mid-size Medicare agent and agency are going to be the ones left cleaning up the scraps when this if these caps on administrative fees come into play. I also think it's important that when they're talking about the caps on these administrative fees, they're talking about something in the $31 to $32 range per head, as if that's the only administrative burden, especially when they're talking about the cost of driving to houses, the cost of hiring administrative staff to help our clients, because an agent or a broker typically sets up a business at some point where they have staff members that are paid, $20 an hour to help service their clients. So the fact that they think that a $31 charge one time would be enough to offset administrative costs is a little silly. And so I don't really think that those administrative costs are out of whack. And I believe that these small regional group plan sponsors can easily afford those costs. And if anything, they should be asked to pay more because the cost has gone up dramatically with inflation, which I know is a word Senator Elizabeth Warren hates to hear. But it has gone up. The costs continue to go up. The costs I would love to bring in Senator Elizabeth Warren to our agency so that she can see the cost associated with servicing, marketing, distributing, and keeping these these policyholders happy and on the same plan. Because our profit requires us to keep them happy for a long time. Anytime that we're just treating this like a retail transaction, which some groups do. I've already talked about those groups. These large publicly traded distribution companies, unfortunately, treat this like a retail transaction. They know that their lifetime value is, $800 or $900, so they'll spend $600 to make $700, $800, $900. We don't do that. It's not we're not in that large group, but we are one of those groups that would be affected by the changing of administrative fees. And it would impact the solvency of a lot of really, really solid agencies around the country that are doing the right thing. I'm not sure how it would impact those large call centers. I'm sure that the cost per acquisition for clients would go down, and so that might offset it over the next 2 or 3 years. But we'll see. Hopefully, there's some more discussion, and they can actually come to see that there's more costs associated with this than they believe. Okay, I'm going to watch one more video and we'll be able to wrap up some of these points.
This week, millions of people will begin the process of choosing a Medicare plan through open enrollment. And one option is to stay with traditional Medicare. The other is to enroll in one of the many Medicare Advantage plans, or MA, as people often refer to it, which allows these for-profit health insurance companies to offer Medicare coverage. Now, in theory, these private companies should compete on the merits of the coverage they offer. Instead, big MA insurers with a war chest of advertising money use deceptive marketing tactics to lure seniors into the wrong plans. These companies exaggerate benefits, They claim that seniors can keep seeing doctors that are actually out of network, and they deceive seniors about how much they'll spend for out-of-pocket care. This is harmful to seniors, and that's a big part of what this hearing today has been all about.
So the last clip here I'm watching today is Senator Elizabeth Warren's summary, where she's talking to the committee about the deceptive marketing practices of Medicare Advantage carriers, a continuation of some of the other earlier things she said. But she is putting out some pretty accusatory things, saying that they're exaggerating benefits. I don't believe that they're exaggerating benefits. It is non-compliant already. They can be penalized pretty heavily for doing that. She's saying that they are saying that people can still see doctors that are out of network. I don't believe they're saying that anywhere. They're saying that they're not saying that. I don't know where that's being printed. I wish that she would be forced to show, some actual data behind these accusations. But unfortunately, this is how legal proceedings and hearings can kind of go, is people just get to throw out one fact about something and then 5 or 6 misspoken, out of context, statements that then people just buy into because there was one fact about one thing. This hearing, it just a lot of political theater, timed on an upcoming election year. It is, I think, setting the stage for them to make some drastic changes to look like they're helping the beneficiary. I will remind people of the Reagan quote, "I'm from the government and I'm here to help," is, a very scary thing to hear sometimes. Regulation almost always ends up costing the average citizen more money. And I think that's what you'll see here, is the average citizen is going to be impacted. In the name of one or two, let's screw over a whole bunch of other people. And that's unfortunate. I know I said that a lot. It's unfortunate that this is being perpetuated this way. If you're a consumer looking for help with Medicare, use an agent or brokerage while you can that offers everything, so that we can come into it with as little bias as possible. Anybody that's selling something is going to have some bias. But if you're using a broker that can offer everything, and our mission statement here is help, is to help each individual Medicare beneficiary, regardless of, what that means. If we help them with a standalone Part B plan, if we help them by telling them the plan that they're on is the best one and they should keep it, we're helping them. We're on a mission to help 1 million of our 70 million nationwide Medicare beneficiaries. And of those 1 million, we count every interaction with one, leaving them as good or better than we found them, as helping them. Because when we know that when one of our agents talks to them, that we're not going to hurt them. And sometimes all you got to do to help somebody is not hurt them, when there's other people out there that will. There are bad agencies out there. There are bad agents out there. But this committee is overblowing that. And instead of focusing on the couple of organizations that are really, really polluting the entire marketplace, and 1 or 2 marketing practices, they keep coming up with new rules that I think they're even struggling to enforce. And now if they come up with these compensation rules, there'll probably be sleight of hand tricks to get around that. And I think the carriers will begin to potentially buy up more of their own distribution, because once they own the distribution and these agents are their employees, they can pretty much pay them whatever they want to. So this entire charade is, made for political theater. But if you need help with a Medicare plan or an individual health plan under 65, if you're disabled, if you're turning 65, if you're retiring, or if you've been on Medicare for a while and think you might have the wrong plan or just shopping your prices, you can give us a call at 662-844-3300 or head over to BobbyBrockInsurance.com. Thank you so much for watching today.